There are 4 common risk factors for EOE. The first is sex. The second is race. Third is having an atopic background, and we'll explain what that means. And fourth can be a family history. With the first one, with being a sex, we know that males are definitely more affected than females. Anywhere from about, depends on who's describing, but at least 2/3 to even 3/4 of patients affected are males. But with all these risk factors, none are exclusive, meaning it's not as though girls can't get it, or if you don't have a family history, you can't get it. With race, it is something that's previously been described as a problem amongst Caucasians more so, and depends on your environment where you are. We're also seeing it in South Asians, like people from the Indian subcontinent, for example, but seems not as represented in Southeast Asians. Again, not universal, and there are patients that we have from all ethnicities and backgrounds. The third risk factor is atopy. And this is can be one of the tip-offs for whether we should look for this as well. Atopy is a general term we use for tendency to develop allergic type conditions. That could include, for example, eczema, asthma, environmental allergies, or sometimes we call it allergic rhinoconjunctivitis, but that's a kind of fancy way to say kind of hay fever type thing. At least 2/3 of our patients have a background of at least one of those conditions. And sometimes once you have one, you kind of cluster to have more. But again, a 1/3 or even 1/4 of our population don't have that. So it's not protective to not have that background. You can still have it in a patient who has none of those things in their past history. And family history, if it's there, for example, if, father has a condition where he's had difficulty swallowing, or even better yet, they've had a history of difficulty swallowing or food getting stuck, that's great. That'll make us think of it even quicker. But for the most part, about 90% of our families don't have any family history. So it's still something that we ask about, but it doesn't need to be there. So remember, with these things, we're still learning a lot about our risk factors. And it's a relatively new condition in the sense that this was really only described in the late 90s in terms of, and our following of these patients has been better and more systematic for 20 years. So as time goes on, we are hoping to better understanding the individual risk factors, but these are the most common ones we have right now. In terms of triggers, we definitely think as food as the dominant trigger, but as you know, for humans, eating is a necessity. So it's not something you can fully avoid, but that's where we talk about individualizing it to see if individual food groups are a trigger for the individual patient. As mentioned, dairy and wheat are common ones. Doesn't mean they should fully avoid all the time, and there's patients where it's not their trigger. So we have to find the right balance. And it is true that after diagnosis, the first few years, it's more trials and errors until we kind of narrowed it to a small group, especially if we're doing dietary elimination. And it does mean several anesthetics related to several scopes in the first few years, and then we can get into maintenance. In addition to the foods, there is epidemiologic, which means kind of larger associations with environmental allergies as well. Especially some describe a seasonal effect. If you're, for example, sensitive to grass, maybe some people are describing worse problems through kind of spring and summer. So that's another thing, but again, that's not for everybody.